this week on the BackTable podcast.
Do not be complacent. You have to be open for new ideas, knowledge, and technique in treating patients. You always want to improve your outcomes. So you have to stay hungry all the time. I go through a self-assessment every couple months. What can I do to improve this practice and how to make it better?
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on backtable.com. Today, we're happy to continue our spine and pain-related topics with another world expert joining us today, Dr. Dan Nguyen, interventional neuroradiologist from Neuroradiology and Pain Solutions of Oklahoma. Dr. Nguyen, welcome to the show, and thanks for your time.
Well, thanks, Jacob. It's a pleasure being here. I've been a fan of yours and BackTable for some time now.
Well, we're excited to have you today, and I have to say we're very lucky. We recently had the chance to discuss with Dr. Jack Jennings, and we're continuing with the ASSR dynasty. Lucky to have another prior president of the American Society of Spine Radiology today. So we really appreciate your expertise in coming on. And you are an expert in many of these areas of pain interventions. And one of the things we really wanted to get your expertise on is the field of headache interventions, which is something a little bit out of the ordinary for radiologists to be practicing. And so really excited to dive into this topic today. Before we begin, could you just tell us about your life and your training path, how you came to be doing pain interventions in your career, and tell us a little bit about your current practice?
Oh, okay. Well, most of you know me. I wasn't born in the U.S. I actually immigrated here back in 1975 from South Vietnam. And we, through the gracious government here in the U.S., came to Northern California with just a bag, really. I mean, it was not a planned trip. And we stayed there. And somehow in 2 years, my mother and father bought a house, and they've been residing there. I left there. I went to college there, and then I left there to go to medical school back in the East Coast, and I have not returned since then, back in the early 80s.
You've kind of been all around, all over since then. You've really traveled all over the U.S. during your career.
Well, through my journey, it's been one of the things I really enjoy was meeting the different type of people, what their passion was, and learn from them. And many of those have become and still are my friends to this day. When I was in Washington, D.C., my mentor, Dieter Schellinger, got me interested in the spine. And then in that area at that time was kind of like the mecca of vertebral augmentation. As you know, that came from France, but it was brought to the Virginia area. And then in the Washington, D.C. area is where people like Greg Zorski, John Mathis, Orlando Ortiz, Wayne Olin, Kieran Murphy, and so on, they were all right there within driving distance from me. And I met them and learned to respect them and became friends with them. And it kind of got me this whole journey of interventional, which I never knew of, doing my initial going to radiology.
Yeah, that's pretty amazing that so many of the world experts were concentrated in that local proximity, and you carried the torch on from them. It's very exciting to hear about that.
Yeah, it was just a great experience. And then I came from Washington, D.C., and I went there next to Penn State and spent the next 13 years up there. Kind of had a great opportunity to build a division. And from there, I kind of span out from what I was set to do was build a division of diagnostic imaging, but my focus was always on the side was intervention. And, despite doing stroke and aneurysm work at that time, I became much more interested in the musculoskeletal or neurological pain that kind of led me to today, what I'm doing. And I kind of honed my skills and learned from a lot of great and more expert than me at that time, and just kind of dive into the anatomy and the function and how can I perfect my skill set through those interactions.
Amazing. And so you've had an exceptional career in academic radiology, and more recently, you've brought your talents to the community level in Oklahoma City. Can you tell us about that transition and what's the current practice like?
Absolutely. That was a focus. I've been thinking about what do I want to do for the rest of my career, and I had a wonderful time in academia and met a lot of friends and students, and many of those went on to do great things. But inside, I knew I wanted to do something different. So I would say probably 6-7 years ago, I had a conversation with someone of our mutual friends here in Oklahoma City, Dr. Beall, and he talked to me and he told me, come to Oklahoma City, and I go, no, I'm not gonna. He had a vision, Oklahoma, and I go, I'm from the East Coast, big city, but when he invited me one weekend to come here with my family, and I took that offer, and it kind of fell in love with the area. And what I can do here, and that sets the motion to what I want to do, and I want to focus something different at that part of my career. So I came here and opened a practice here, focus on patient outcome and latest technology, bring the treatment to them, integrate research. And then hopefully soon I'll be doing education just like I did in academia, but now at this level where I can have some control over it.
Very, very exciting. It sounds very complementary to your experience so far, and really cool that you get to bring those skills that you've honed over decades into a different environment. And so is your current practice predominantly interventional and clinical at this point?
It's completely, I would say, 95% clinical. We do some trials here, clinical trial, and then I still read films because I feel like some aspect of it I want to maintain. I don't want to lose. I've used it. I've learned all through these years, and I don't want to lose it. So I still do of that. Really, just kind of maintain my skill more of in that perspective. So. And it's really just pure clinical. I see patient, I treat them, I see them back. And some of these patients I have in our practice, they've been with me for the last 4 years. So it's a long-term relationship that I have with a lot of these very, very dear to heart patients of mine. Yeah.
That's wonderful. That sounds really gratifying to be able to build up that longitudinal relationship with the patient. Sometimes in radiology, especially in training, we don't get the opportunity to do that so much. We're consulted for an intervention, often in the acute term, and we don't have the opportunity to see that. I imagine that adds a different dimension to your work.
And that's the one thing that I must say that I see a transition in our field. I think when I entered this about over 20 years ago, it's exactly what you said. It's kind of like a point of care, and then that's it. But I've been seeing many of us have transitioned to this new model, and I presume in the coming years, more and more like yourself will be doing this as well. Just, that's the only way to deliver best of care, because these patients as well as anyone else and what they need and stuff like that. And if we don't have that continuity of care, we tend to lose that perspective. We're kind of depending on someone else who may not know the patient from the way that know them, and the pain and the location of that. And I think I'm seeing that quite a lot in our field. I'm very happy to see that, actually.
I agree completely. It's been really exciting to see that organically happening over the last few years. And I would say that earlier on in the field of interventional radiology, which again really encompasses, VIR as well as interventional neuroradiology and musculoskeletal radiology, really any radiologist doing interventions, we have the imaging expertise and the procedural expertise, and we have the theoretical clinical acumen. It's just that it's not so much typically a focus throughout our training. And earlier in our field's history, I think we didn't really have these sort of role models for how that's kind of done. And now our entire field is benefiting from a lot of the trailblazing work of people like Doug Beall, Wayne Nguyen, and yourself, who have gone out and shown that we can do this, and it adds a very gratifying and important element to the work. much better to be able to evaluate the patient yourself rather than receive a request for an L4-5 epidural steroid injection. But if you, as a radiologist, examine the patient yourself and correlate with the imaging findings, you kind of say, this doesn't really correspond with, radicular symptoms. And then you use all that to come up with the best treatment plan. It just seems like a better way of doing things.
Absolutely. Absolutely. I mean, it could be starting just a basic epidural, but then you will see, wow, the patient actually have lumbar spine stenosis. There's other things that I can help them. And it takes on that kind of role if you specifically engage yourself with the patient in a continual care pattern.
Absolutely. And on that topic, how would you say that your background in neuroradiology and specifically your experience with interventional neuroradiology, how does that inform your diagnostic and therapeutic approach, bringing those skills in?
That's the groundwork. I think it's very important that every patient that comes to my office, my staff know that, despite that we have an official report elsewhere, that I specifically ask them to bring a CD, or in rare occasion they have films, but a specific CD of an outside to all of them, anything that pertains to the area of their pain, bring them. Every patient, I look at them and actually show them on the TV what I'm thinking, and so they're understanding what, why I'm doing this. And because of that, the background of imaging and spatial relational anatomy, you kind of appreciate the patient, where the pain, and you actually, most of the time, you do find things that were missed, and no fault to anybody. I mean, it's hard to read a study without any information remotely, and so you have a patient right here, you're looking at them, I say, okay, wow, there it is. There's the problem. And then you point out to the patient, get, their eyes, I go, wow, okay, this is really, and they take a role in their care now. They understand why I'm doing this. And that's very important. So I think the background I had in imaging really served as a baseline that launched the next level into intervention.
I love that. It's in our training, we spend the majority of our time on imaging, perhaps some would say to our detriment, but I don't think so. I think that it adds a different dimension to the clinical evaluation. And like you said, we never take the report at face value, even if it's done by a colleague radiologist of ours who we agree with and admire their work. It's just second nature based on how we function in residency and fellowship to always look at the imaging ourselves and confirm that. And also, it definitely is crucial for the procedural planning when it comes to that point. And so on that note, I'd actually like to transition a little bit to talking about some of the headache interventions. And one of the things I've been thinking about with this, and I'll say I haven't performed any headache interventions at this point in my career other than for CSF hypotension. And so I know a lot of these interventions involve really very eloquent and small real estate, particularly at the skull base. And as radiologists, whether we're trained in neuroradiology or not, we throughout our training read thousands of head CTs. It's probably one of the single most common studies that we read, and often for the indication of headache. And yet, most of the time, our impression is sort of no acute intracranial abnormality. And so I'm wondering if you can talk about the clinical evaluation of headache, and then how does the imaging aspect come into that? Are there often any imaging correlates to these headache syndromes, and how do you spin that all together?
Well, I think the imaging that we see day in and day out is coming, a lot of it coming from the ER. And so they look for big stuff, the big intracranial hemorrhage or mass or unexpected mets or something. So yeah, we see that now, but even normal people have headache. You look at that, most of the time it's normal. And then it's really hard to correlate that clinically unless you have a patient sitting in front of you and describe to me, Doc, I have this pain right over my eyebrow, or I have this pain right in my jaw lines, some specific region now gets you thinking of the neuroanatomy supply of the face. And then you kind of go back there and look at that. And sometimes you find something, but most of the time it's negative. Certain things like trigeminal neuralgia, they have this pain, a kind of electrical pain over their face, but you don't see anything on the imaging. But every once in a while you see a vessel next to it, which probably was not, to be fair, difficult to catch in the front end from the original interpreter. But you can suggest that maybe there's a vascular compression syndrome that may be causing that. So on rare occasion, you find that most of the time you don't, but it's good. But then now you kind of go back to your understanding of the neuroanatomy of the face. And then you kind of troubleshoot. Okay, if it's in the front of the ear, maybe it's auriculotemporal nerve that may be bothersome. Some other area, maybe supraorbital, infraorbital, mental. There's different nerve that supplies the face, and our understanding of the anatomy helps us to kind of hone down now and say, okay, we'll try the most superficial approach, and then we'll dive into the deep part of the skull and facial region as a secondary backup option.
And when you started your practice in Oklahoma City, what was your approach to raise awareness that you were offering these therapies? What kind of physicians did you approach, and how are patients coming to you now?
Yeah, so when I came here, as anyone else, no one knew of you. So I just start with my basic, what I know, at that time. And what I knew was exactly what you say is spontaneous intracranial hypotension. And I kind of start with the group of practitioners that deal with this the most, which is most of the time the headache doctor. And there's not too many of them in most cities. And so, but each main center will have one or several of those. And that's how I started. I kind of introduce myself and say, okay, well, there's this entity, and then the conversation lead to other areas, like what I'm doing today. So getting that face-to-face interaction with someone, the old-fashioned way, is very effective. And most of them, I give them my cell number. I freely, say, text me, call me, whatever you need, just do that. And from there, I also obviously had to learn about the patient-directed digital marketing for my kids, and how we can do that, part of that too. And so before you know it, people know there's someone here in Oklahoma that does this kind of thing. And so it infiltrates very quickly because there's not too many of us doing that too. So it's kind of everyone's searching for a partner in this arena. And that's how it kind of built up from here, kind of organically, so to speak, with some intent. Sometimes you can go to this center and I offer to do a grand rounds on headaches. And I talk about different things, and kind of that too. And so it's a combination of things. Since I'm not in a medical center, so to speak, I have to purposely go out and develop my relationship with different people in this area. And that's how it started.
Excellent. So a bit of deliberate practice building with respect to the headache, but it sounds like as things have gone on, you're getting a mixture of both physician-referred and self-referred patients. And so you're probably seeing a wide variety of the manifestations of headache. And with that, I imagine starting out from SIH, you had to basically bring more tools into your armamentarium. And can you just briefly talk about the different headache entities? Maybe just list the top 5 and what are the therapeutic approaches for those?
Yeah. So, most of this, what I'm saying right now, I did not know back then either. It's one of those things that I think when you're doing something new, you kind of start to dive into it and you start to read more. You start to look at the research and other society, what they're doing, and it kind of got your interest. And I go, wow, this whole area is a little more broader than I thought, And so from there, typically today, I'm seeing a lot of certainly the migrainous headache that has an occipital component to it. And that could be just ranging from musculogenic nature, where we can do some simple trigger point, to really an occipital, painful with palpation, occipital neuralgia, where we can do, a test injection, and then we can do some kind of ablative therapy, and then bring on neuromodulation, peripheral nerve nausea. I didn't even know what that was 4 years ago when I came to Oklahoma. What is that? And so those kind of things, I learned from my colleagues in the interventional pain world through my interaction nationally with them, and brought that into our practice as well. So that's the most, I think, occipital neuralgia that I deal with. The other one is a cervicogenic headache, which, you kind of have to rule out. There's some people who have the pain from the spine. I did not know there was a nice cervical trigeminal connection in the brain, where your pain in the neck could manifest along the face and vice versa. There's that deep inherent connection. And so you kind of have to work through that too. Was it coming from the spine where you're having pain in the face? So, typical things you do for that is okay, well, I look at the X-ray or the CT or MRI, whatever that is, and see if there's any potential cause of that, and do some trial injection, and then go from there to ablative therapy and again, neuromodulation if needed. Of late, I've been getting a lot of trigeminal neuralgia, mainly from trigeminal neuralgia centers around the Oklahoma State connection, and people with MS are getting a lot of this, and certainly deal with it from an imaging review and looking for vascular compression. But they have these really terrible, shocking pain that, I feel so badly for these patients to live with this. So we've been looking at ways to deal with that, depending on what region it comes from, whether it's V1, V2, V3. And we know from the anatomy, there's areas of where these nerves come from. And we typically do a trial injection of those areas, like V1, supraorbital, supratrochlear, and then V2 infraorbital, and then in foramen rotundum, we can access that through CT if you need to. And then the V3, superficially mental nerve, and then could be as far back as foraminal valley, where you can do that. And I was very shy with fluoro beginning, but I discovered fluoroscopic guidance doing that is so easy once you get to know where you can see it, and it's much easier than CT to get there.
I get a little bit antsy when I'm looking at fluoro pictures of the skull base and a needle going through someone's face. And, in radiology, we look at skull radiographs. To me, the diagnostic skull radiograph probably has one of the lowest yields, and yet there's quite a bit that you can see on it, especially for procedural guidance. Could you talk about the movement from CT to fluoro, and how did you kind of mentally get over that hump?
You're absolutely right about this. And I am so appreciative of the early days of fluoroscopy, what they used to diagnose things. We're talking about, decades ago. And because they see so many things on there that we don't appreciate today, all the pathology. And so it took me kind of looking at the fluoro picture and then look side by side with the MRI and the CT. And I kind of look at there and go, well, if I take this approach, what is the worst thing that I can do? What things I need to avoid? And when I look at the approach to the foraminal valley, I go, wow, it's not really a lot of things here. It's not a carotid that's going to be there or anything. And if I take this angle, there's really not a lot of things other than just sharpen my skill of advancing the needle meticulously without, changing the direction and cause a lot of aggravation because it's a very sensitive area of the face. So once I overcome the unknown of, oh, wow, this is putting someone needle into the face, I get really, once I understand the anatomy, I go, it's really pretty safe if you just develop a right visual approach of it. And that's what we spend a lot to look at that. And once you have that, it's a straight shot into the foramen from the cheek area.
It's really encouraging. Much easier than expected, it sounds like.
It is. I mean, like I say, it's understanding the anatomy and look at the things that we know, from cross-sectional image and go, what is there that I have to avoid? That would be devastation if I hit it, And once I overcame that, I didn't see anything then it was just a matter of getting used to the view from the fluoral perspective. And it's, so easy to do. It's just like C1, C2. You know what's going on there. I find it much easier to do in fluoral than CT guided C1, C2. I can do a fraction of the time doing fluoral because it doesn't take a lot to set up. And you can make some minor adjustment when you get the needle. With CT, sometimes the patient move a little bit, then you have to reset again. It's just a little more time consuming. But there are times when you have to use CT, but there's some transitional phase where you just have to kind of to yourself, look at the imaging and see what is there that I need to be not hitting. And once you see that, go, wow, okay. And then you just kind of overcome your fear, like heights,
Yeah, it's kind of a mental block. And once you understand, like you said, the procedure is done in the same manner as in CT in terms of the needle trajectory, where we just are using image guidance in a different manner. And I think it's something it's very important for trainees of my cohort in that we do a lot of procedures under CT, current resident and fellows in training. And I think it has to do with probably availability and the comfort level. And it's understandable. We do a lot more probably complex interventions, including drainages and things of that nature. And it's with that kind of variable anatomy, it is good to have the three-dimensional aspect. But when you're doing something like a trigeminal nerve block, a Gasserian ganglion nerve block, as you said, you're not going to be impinging on the carotid. There's not other critical structures nearby, and you have a little bit more of a reproducible approach. So knowing that CT and fluoro are both available, and of course always using the approach that's the safest for the patient, but knowing that it's definitely feasible with both.
There's one other modality that I want to kind of give a little bit a hedge. It's ultrasound. I mean, I think we have in our radiology, we use ultrasound quite a lot, but maybe not in certain subspecialty in radiology, but is another modality that I integrate into our practice, especially in the superficial face, and then also peripheral nerve in the extremities too. But that's another thing that I think has a large part in our guidance. Sometimes it's actually easier doing that way than any other ways that we're thus far been introduced to. So
absolutely, a lot of love for ultrasound. It's such a dynamic modality. We tend to get quite a bit of exposure to this during our training. And so adapting it to some of these places where probably in training we haven't used it much in the upper cervical spine or the face, it's definitely an important thing to do. And you mentioned a few minutes ago that you've learned a lot from interventional pain colleagues. And I really want to emphasize that point because a lot of people in that area have really done some of the pioneering work on these headache interventions. In particular, Samer Nowrouz, who anesthesia, interventional pain titan, who his book that you recommended to me, Interventional Management of Head and Face Pain, is sort of the current Bible on these things and represents culmination of a lot of the anatomic studies and development of these techniques over time. And it's just something that I want to put out there. I think that our specialty, radiology and the interventional subspecialties, we gain a lot by interfacing with the specific interventional pain and pain management communities because we have complementary approaches. And a lot of this work has been done by people like Dr. Nowrouz, who were singularly focused on these areas. And in particular with ultrasound, he's described a lot of the ultrasound guided approaches to upper cervical blocks. And we learn a lot by incorporating those approaches, I think.
And, you're so right there, what you said there, Jake. I mean, it's one of the things I think makes the whole field, and not just individual, but as a society or a field, is learn from each other. And that's something that I've always carried with me. Is I always, sometimes I have my ways of doing it. I've always kind of keep my mind open about what other ways people are doing the same thing in different ways. And that's the only way you get better, is you learn from each other. I learned so much from my surgical colleague doing spine and neurosurgical colleague, how they do it. And the approach they do, I incorporate into my practice on the other areas of the body. And so, my goal one day is with my recent opportunity from a national society perspective, is trying to have a little more crosstalk with the interventional pain, especially with the ASSR, any of the ASNR, trying to get more interventional pain integration into our programming and work through between several society to try to get a better outcome. We learn so much from each other, and that's how we're going to grow as a whole. I can't disagree anymore with that. And Dr. Naruse was one of early mentor of mine, trying to introduce me to this area. So I really respect him.
I absolutely agree with all that. And I just have to say the ASSR meeting, I believe it was 21 during your tenure as president, that was in the midst of COVID. So things were pretty virtual. And I'm sorry, it may have been 2020 or 21, but it was kind of a fortuitous occurrence for me, because I remember I was on Twitter and I saw that the ASSR shared, our annual meeting is going on, it's virtual, $25 for residents. And that was the quickest and best $25 I've spent. And it was an amazing meeting. I learned so much just about how many different interventions are coming out in the spine and the spine related world. And I really loved the interdisciplinary nature of it. We had anesthesiologists, neurosurgeons, interventional pain specialists, and of course, many different neuro and musculoskeletal and interventional radiologists sharing these different aspects about their practice and the cutting edge. And for me, that was a huge moment in my training, realizing that not everything interventional radiology is necessarily showing up at the more mainstream IR meetings. And so I tell almost everyone I know that ASSR is one of the best meetings you can go to for this area, just because it's so broad. So I do want to commend you on it was an excellent meeting, especially given the circumstances with COVID kind of throwing everything out of the loop and not being able to be in New Orleans directly. But I really hope to see the ASSR continue that momentum and advancing this area in that interdisciplinary aspect.
I'm so happy you said that, because it was a nerve-wracking when I could not have a meeting in New Orleans. I was waiting so long for that, and I had so much great plans for that. When that was pulled underneath me, I was very disappointed. But then the opportunity came at that point was to make the meeting bigger, and so I purposely made it bigger than usually. And so I want to integrate as many multidiscipline into that meeting. And like I said, I had Dr. Deere, Dr. Saeed from the Aspen. We had people from the neurosurgical, orthopedics. It was just people that share the same passion in treating certain body part. And that was my goal. I said, I'm going to make this bigger, and instead of typical 2 session, I double that. And so we were able to get a lot of people and get into the meeting and kind of get a very multidisciplinary discussion about certain pathology, other than headache and spine, but many other ways, and imaging too. And a lot of those colleagues told me, "Wow, I didn't realize you guys have such a society. I thought you guys just in imaging, I go, no, that's our strength, that's our core, but we do many, many other things. And so I'm hoping to see that this upcoming year as well.
Excellent. Well, we'll definitely look forward to that. And there's no question that the future of medicine is multidisciplinary and benefiting from that cross-pollination that you've talked about. And I think that it's a positive sum game for the different specialties in the world of spine to be communicating together, sharing techniques and insight. That way we can all better take care of patients, and these problems, headache, low back pain, they're not rare. There's not a small market for them. Most adults in their life are going to, at some point or other, struggle with these sorts of things. And so the better we all can be as physicians, clinicians, and for us in particular as interventionalists, that's only good for the patient. So I really commend that and really happy to see things growing in that area. And I'd like to take it back to talking about the procedures a little bit. You were giving quite a description about the trigeminal neuralgia approach. And so this is one in particular that I think among headache disorders, it really sort of stands out, at least to me, because as you said, this is often this debilitating, lancinating pain. And so once the pharmacologic therapy has sort of been maximized or has been found to be ineffectual, interventions or aside from cyberknife surgery could be one of the few options. And so this is kind of a classic interventional radiology scenario where there really is no other option, and we can potentially provide an excellent and minimally invasive alternative. So could you just talk about your approach in terms of applying the diagnostic block and then the ablation? What are the specifics in the ablation procedure? And what are some things to watch out for when you're treating these patients?
Yeah, so trigeminal neuralgia is quite, you think of the main three branches of the trigeminal nerve. The Gasserian ganglia is deep to the foraminal valley. It's in there. And so to approach that, if you have suspicion of a certain branch or regional area, I usually try to do the most peripheral nerve branch of that. So like I said, if it's V1, I look at supraorbital, supratrochlear, and that I use ultrasound to get to. Pretty easy, very superficial. You can see it ultrasound, the tunnel. If it's V2, I typically look at perhaps at infraorbital as one aspect, and that's ultrasound. The foramen rotundum deals specifically with V2. If that's something we look at to do, and that will be a CT guidance to get into with this needle, thin needle. And then if it's V3, again, I look at mental nerve, sometimes the alveolar nerve, just behind the angle of the jaw. It's another option we can try to get there. Pretty accessible. And then the ovale we had spoken about, where that usually is a test injection. And if this test injection, diagnostic injection, proves to be fruitful in terms of giving them some kind of relief, then we usually typically talk about RFA as the next possible thing. And so, which is radiofrequency ablation. So it's the same technology we use everywhere else in the body. Lately, I've been trying to look at other ways, some kind of neuromodulation technique out there. The unfortunate part right now, a lot of the neuromodulation we have out there is not deemed above the head. It's really head down. But I think that's an exciting field that people are working on, and hopefully one day get approval to try to put these small, especially small leads we have now, to put into next to those nerve and stimulate it so that they don't send the pain signal back to the brain for interpretation. And so there are devices out there that we can start considering about that. And I'm starting to look at ways to try to apply that now, but it's not mainstream because approval is a bear with these insurance company about these areas.
Yeah, absolutely. As we've talked about with Dr. Beall before, often the regulatory apparatus lags significantly behind what we're technically capable of doing.
Yeah. And then another areas of the face pain that I've discovered is the grand central station because there's so much parasympathetic and somatic nerve goes through is the sphenopalatine ganglia. That area is a small little area that you see behind the maxillary sinus. And I knew from my vascular day, other than internal maxillary artery and some of the thing goes in there, it really didn't make too much sense for me to ever be in there for any other reason. But it is a very highly neural-rich network of the face and mouth and pain of the face. And so if the other one doesn't help, and if the distribution is kind of a little broader, more than just one territory, that's another area that I target. And while you can do this effectively using fluoro, CT is much easier. As you may have seen some pictures, you just you see it and you target into the superficial and just get the needle there, and it's pretty effective. And with this, we go for our RFA there as well.
Excellent.
So those are typical the trigeminal facial pain, the area that I might approach. That's in the front, and then the back. There's the occipital. There's the auriculotemporal, there's a greater temporal nerve. So there's some other nerves back there that we can look at as well for the head pain.
One question I had about those is many of these nerves that you're talking about are extremely superficial. And one thing I was wondering about is a test injection is one thing, but with the ablation in particular, are there special considerations when you're ablating such a superficial target?
Yeah, so you want to make sure that you take the longest path toward the nerve so that you can have the ablation portion of the needle underneath the skin, because you don't want to cause a skin burn, and that could happen if you're too superficial. So some of these nerves, yes, they do come superficial, but there's a deep section to that, like auriculotemporal. There is a deep portion that you can get to. You can see it relatively with ultrasound, and you stimulate it. When you get there, you stimulate it with sensory, and typically that gives you some sense that you're in the region, and then you apply the heat for the ablative portion.
Excellent. And on a similar note, in terms of avoiding the complications, dreaded complication in this area is, particularly with the trigeminal ablation, is the anesthesia dolorosa. Could you tell our listeners a little bit about this phenomenon? What causes it? How do we avoid it?
Yeah, it's hard to predict if the patient get that, or the complication from after the effect. I haven't yet discovered predictively from the front end if they get it. So you discuss these complications, like say the V3. When you ablate, there is some portion of tongue numbness, mouth numbness, so there's some of that peripheral, but, and you weigh the risk that with the patient, what pain they're having from the distribution, does it outweigh the potential complication of that? So that's the discussion we do. And when you do that with the patient in the front end and kind of give them the possible, and they'll weigh what they're living, and a lot of them are having really bad quality of life to a point like one of my patients can't even eat in front of their kids because their face is just, electrical all the time. They're willing to take the negative effect of the complication from that. But I haven't seen a lot of that. But yeah, I don't know how to avoid when it does come, because you do know front end is possible. Just having that discussion in the front end helps a lot if it does happen.
Sure. Absolutely important to discuss the possibilities, even if remote. And for our listeners who may not know about this clinical entity, it's one I only learned about recently. That anesthesia dolorosa, to my understanding, Dr. Nguyen, it's a rare complication of iatrogenic action at the Gausserian ganglion, and it can basically cause facial numbness, but with terrible pain as well. And at that point, that's a tough situation, since we've used one of the Hail Mary options for pain of this region. So it sounds like it's potentially using a larger ablation zone could make you more prone to doing that. And so there are pretty well described techniques to the time and the energy for RF ablation, and these that are more or less time honored because it's been worked out over decades.
Yeah, exactly. It is. I mean, and it happens with the other technique, like you say, gamma knife. People, how specific it is described, people get the complication afterward as well. So it's just one of those unfortunate part that we can't predict from the front end, that if it's going to happen as well. So,
but it sounds like most of these patients with trigeminal neuralgia are benefiting quite a bit from these procedures.
I think so. I've, knock on wood, I haven't had any kind of serious complication thus far from this clinical offering thus far.
Excellent. Well, it's definitely something, there's a huge need for it in most communities. And I think it's something that the specialists with the skill set of interventional radiologists could definitely be offering. And on that note, that's kind of my last question for interventional radiologists who want to start offering headache interventions for their patients. What would be some words of advice for them, good first cases or areas to focus on and strategies to build referrals and early successes?
Yeah, well, that's a good question. I struggled with this 4 years ago as well. So this is very fresh on my mind, how I did it. Not necessarily the only way or the right way, but I kind of stepped back on my drive here to Oklahoma from the East Coast. I thought, well, how am I going to do this? And so I've taken some business class during my leadership time at the university. And I learned this thing. I don't know, most people may have heard, is SWOT analysis. It's strength, weakness, opportunity, and threats. So you kind of take that approach first. You look at your strength. What do you have now that you would say can strength? I mean, do you have the personality, facility, the people in the team that can do that? Do you have the skill that you feel confident doing that? So you want to make a certain list of that, and then I look at next what's my weakness. What am I weak in? Ultrasound. What am I weak in? Understand the anatomy, or just maybe review things I haven't seen in some time in this light. What can I do to strengthen? And the idea here is try to convert those weaknesses into strength after you reassess and make alteration, for additional courses, webinars, or sometime develop some kind of mentor that can point you direction to correct your weaknesses. And then I look at my opportunity, looking around your practice area. Who's doing this kind of thing that you can partner with? Who else is doing this kind of thing in your area? That you can look at the website to some of the practices around, see if they do that. And then perhaps, like I spoke earlier, pay them a visit, talk to them, give some grand rounds, develop personal relationship to open those opportunities up. And then lastly is look at the threats. Is someone else doing better than we are? What we have to do to kind of overcome that. Efficiency or supplies, or which is more national reimbursement, what we used to do. Now no longer, we can't do because of reimbursement. But another that I've added since then is, so instead of SWOT, SWOT, it's now SWOT, add H to it, it's hunger. Hunger, I put there because do not be complacent. You have to be open for new ideas, knowledge, and technique in treating patients. You always want to improve your outcomes. So you have to stay hunger all the time. I go through a self-assessment every couple months. What can I do to improve this practice and how to make it better? In terms of what you say about some of the first cases you do, we're all familiar as radiologists how to, with the myelogram and interpretation of it. There's a lot of new techniques that are developed out there to diagnose and treat SIH. Many of you will meet them at ASSR meeting or ASNR meeting. But there's other dedicated headaches meeting across the country that talks about that. So I think that's a good start because that's your baseline comfort zone. And I think the other things you probably could start early with fairly good success is occipital headache and cervicogenic headache. And those are relatively a lot of them out there. And you can do some of that early on and get pretty good success from there.
Well, thank you so much. A lot of great advice right there. And is there a way that our listeners, specialists who are interested in starting at this kind of practice, can they reach out to you for guidance in any way?
Oh, you bet. I'm available anytime. You can find me most of the social media, and certainly I can send you my email afterward.
Dr. Nguyen can be found on Twitter at neuroradiology. I'm always really impressed that you managed to get the coveted neuroradiology handle. You must have gotten on pretty early on that.
I did. When I didn't even know what Twitter is about, I just register it. It's not. I've had some offering people to take that handle away from me, but it's just one of my things. I've had it for like, oh gosh, I think 12, 13 years, whatever it is.
Tough to give that away, especially, pretty great to be the king of Twitter neuroradiology. But I definitely recommend our listeners follow Dr. Nguyen. He shares some great, insightful cases, including some of the ones we've talked about. And we haven't even talked about all the other spine work you do today. And of course, that's a big part of your practice as well. And I think you've given our listeners, including me, a lot of great information to think about in terms of the therapies that we can offer for these patients and how we can use our expertise in imaging and bring in the complementary aspect of the detailed nervous anatomy and the approaches that have been worked out by some other specialties. We can definitely bring that all in, integrating new techniques into our practices. And I hope that a lot of our listeners are going to get a lot of value from the things we've discussed today. Are there any other things you'd like to talk about before we end?
No, I just think this is an area I think we can be fairly great contributor to the care of patient. And I think it's another area that we always going to broaden the learn more from each other. And I'm hoping to see more of this at a national level as well, including the ASSR.
Absolutely agree with that. I can't wait to see that as well, and look forward to seeing you and some of the others at some of these meetings coming up. So with that, Dr. Nguyen, I want to thank you so much for your time today. Really enjoyed our conversation and can't wait for our listeners to hear it as well.
Well, thank you again. Thank you for BackTable for this invitation. Thank you, Jacob, for conducting a very fun conversation today.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Junwei Kennebrew.
Thanks again, and see you next time.